Welcome to the deep dive. We take complex topics, boil them down. Today, we've got some great revision notes, listener request actually, focusing on carcinoid tumors.
Hmm.
So if you're revising, looking for that clear, efficient understanding, well, you're definitely in the right place.
Absolutely.
Our mission, pretty simple. Extract the core knowledge, make your revision focused, effective.
And, you know, carcinoid tumors are really interesting. Despite being rare, they have this fascinating contrast. They often grow quite slowly,
Right.
but the hormonal effects, they can be really widespread and pretty significant for the body.
Okay, so let's dive right in then. Carcinoid tumors. What exactly are we talking about here? Let's unpack that.
Okay, so they're a type of neuroendocrine tumor,
Mhm.
neuroendocrine, that just refers to the special cells they come from.
Okay.
These cells are all over the body, acting like little messengers, using hormones. You find lots of them, particularly in the GI tract, the lungs, and the appendix, too.
So, if they're normally messengers in these tumors, are they just like sending too many messages or the wrong kind?
That's actually a really good way to put it. The tumor cells,
Yeah.
they keep that ability to make hormones. Serotonin is the famous one, but others too, other bioactive things.
Uh-uh.
And while they're typically slow growing, and this is important, they do have malignant potential. They can become cancerous and spread.
And that spread, that's often linked to carcinoid syndrome, right? What's the connection?
Yeah, carcinoid syndrome, that often pops up when the tumors, especially if they've spread to the liver, release all those hormones like serotonin straight into the bloodstream.
Oh,
Normally, your liver filters that stuff out, but if you've got metastases in the liver, it just gets overwhelmed.
makes sense.
And what's also interesting, sometimes lung carcinoids can cause the syndrome even without liver mets, because the hormones they release can kind of bypass the liver's filtering system.
Okay, right. So, let me see if I've got this straight. We're talking about fairly uncommon, usually slow-growing tumors, mostly in gut tissues that might be quiet at first, but can turn cancerous, spread. And when they spread, especially liver, lymph nodes, ovaries, peritoneum, spleen, that's when they can trigger this carcinoid syndrome.
Precisely. And the classic symptoms of that syndrome, the ones to remember are bronchospasm, diarrhea, flushing, and those characteristic heart valve issues.
Got it.
Oh, and it's worth mentioning, lung carcinoids, they only make up maybe 1 to 2% of lung cancers,
Yeah.
but they often show up in the bigger airways, tend to be in the right lung, often the middle lobe.
Right. Okay. That's a clear definition. So, knowing what they are, why do they happen? What do we know about the etiology? What kicks this off?
Well, the honest answer is we don't know the exact cause. It's still being researched quite a bit.
Yeah.
We do see links, though, associations with certain genetic syndromes.
Like what?
The notes point to multiple endocrine neoplasia type 1, MEN1, and neurofibromatosis type 1, NF1.
Oh, okay.
These are conditions that already predispose people to tumors in endocrine glands, so it suggests, a potential genetic link for some individuals.
Interesting. So a genetic factor sometimes. What about environmental things? Could they play a role?
Yeah, the notes do mention that possibility. Things like exposure to certain chemicals, maybe toxins like tobacco, smoke, even some occupational hazards.
And it's not definitive.
Exactly. It's crucial to understand these are just potential links. A direct cause and effect isn't proven. Research is ongoing to see if specific exposures might sort of act alongside a genetic predisposition.
Okay, so the exact trigger is still a bit fuzzy, but we have some clues, which leads us nicely to risk factors. Who's more likely to get these?
Well, based on what we just said, a few things stand out. First, family history. If neuroendocrine tumors run in the family, that definitely raises suspicion.
Right.
Then having one of those genetic syndromes, MEN1 or NF1, that increases risk. Older age seems to be a factor too. And exposure to tobacco smoke or certain job-related hazards might also play a part.
So a bit of genetics, maybe some environment.
Yeah, it seems to be a mix, though we're still figuring out the exact weighting of each factor.
Okay, so understanding the risks helps. Now, let's get into how these tumors actually cause problems biologically. The pathophysiology, what's happening, under the hood.
Right. So fundamentally, it's because they come from those neuroendocrine cells.
The messenger cells.
Exactly. Those cells naturally make hormones and other bioactive stuff. In carcinoid tumors, this production just goes into overdrive. It becomes excessive, unregulated.
So too many signals being sent out?
That's it. An overabundance of things like serotonin, but also histamine, bradykinin, prostaglandins. These trigger all sorts of effects around the body. That's what causes the symptoms, the complications. And then the notes also mention there are genetic and molecular changes within the tumor cells themselves driving the actual growth and spread. It's this combination slow growth, but potentially dramatic hormonal effects that makes them tricky.
Right, a double whammy. The tumor growing where it shouldn't and releasing excess hormones, causing system-wide issues. Okay, so for differentiating, what else could it be? Let's talk differentials. For the tumor itself and for the syndrome.
Yeah, this is really key to avoid going down the wrong path. If you suspect a carcinoid tumor, you need to think about other types of neuroendocrine tumors first, obviously.
Makes sense.
Also, gastrointestinal stromal tumors, GI crests, they can occur in the GI tract too. And depending on where the suspected tumor is, you might need to consider primary lung cancer or even just benign non-cancerous growths.
Okay, so other growths mainly. What about the syndrome symptoms? Flushing, diarrhea, wheezing.
Right. For flushing, you've got to rule out common things first, reactions to alcohol, nitrates, maybe spicy food.
Uh-huh.
Then there are conditions like systemic mastocytosis, medullary thyroid cancer. Even menopause can cause flushing. Less commonly, maybe renal cancer, hyperthyroidism.
Wow, quite a list for flushing.
Yeah. For diarrhea, think gastroenteritis, inflammatory bowel disease like Crohn's or colitis. And for bronchospasm, could it be anaphylaxis, asthma? Maybe they inhaled something. Or COPD.
It really shows how nonspecific these symptoms can be on their own. Any quick memory tip for keeping these differentials sorted?
Okay. For the tumor, think other growths in similar places. For the syndrome, focus on that classic triad: flushing, diarrhea, wheezing. Then just brainstorm other common causes for each of those individually.
Okay.
Like for flushing, maybe think farm, foods, spicy alcohol, allergy anaphylaxis, rare tumors, medullary thyroid, menopause, something like that.
Farm. I like that. Okay, useful. Now let's get a sense of scale. How common are these? What's the epidemiology look like?
Well, in the UK, the notes say they're relatively low incidences overall, but it does vary a bit depending on the organ.
Right.
They tend to be diagnosed most often in people age, say, 40s to 60s, but really they can show up at any age.
And globally, any broader stats?
Globally, yeah, they're actually the most common type of neuroendocrine tumor overall.
Yeah.
Incidence is about 2.7 per 100,000 people.
Okay.
Carcinoid syndrome is rarer, maybe 0.27 per 100,000 in the U.S. Interestingly, carcinoid tumors are the second most common digestive cancer.
Really? Second most common.
Yep. Most common sites are small intestine, rectum, colon, pancreas, appendix. And get this, up to 10% are found incidentally at autopsy.
Wow, 10%.
Yeah, suggests many people live with them without knowing. And as we said, family history does increase risk.
That 10% figure really sticks with you, shows how quiet they can be. Okay, so what might a patient actually experience? Clinical features, the signs and symptoms.
It's really variable. Depends a lot on location and hormones being produced. But common things to look out for. Skin flushing is a big one, often early. Think sudden redness, face, neck.
Okay.
Diarrhea is also very common. Breathing issues, wheezing, shortness of breath. Some people get abdominal pain, palpitations like a racing heart, and unexplained weight loss.
And any more specific features that might really point towards carcinoid?
Well, the bronchospasm we mentioned, hypotension, low blood pressure can happen.
Yeah.
Carcinoid heart disease, that damage to heart valves from the hormones, that's a major one. Rarely, you might even see signs of Cushing's syndrome if other hormones are overproduced. And very rarely, pellagra, that's a niacin deficiency. But again, many cases are asymptomatic or just very mild for a long time.
You mentioned variants based on location earlier.
Yes. So gastric ones in the stomach sometimes have this itchy, pruritic flushing and maybe peptic ulcers. Bronchial ones in the lungs can have more prolonged flushing, sometimes even mental changes. And the notes also mention fibrosis elsewhere, like causing hydronephrosis, kidney swelling from urine backup.
And that link with tryptophan you mentioned, can you simplify that a bit?
Sure. Basically, if there's a lot of tumor, especially metastatic, the tumor cells use up a lot of tryptophan to make serotonin.
Okay.
Tryptophan is also needed to make niacin, vitamin B3. So if it's all going to serotonin, you can become deficient in niacin.
Leading to?
Potentially hypoalbuminemia, low protein in the blood, and pellagra, from the 3Ds, dermatitis, diarrhea, dementia.
Got it. And any physical signs a doctor might find on exam?
Yeah, possibly. An abdominal mass, maybe an enlarged liver, hepatomegaly, telangiectasias, those little visible blood vessels on the skin, and sometimes signs of the heart valve problems, like murmurs.
That's a really thorough rundown. Another memory tip, maybe, for the features?
Let's see. How about flushing? Lethargy can happen. Upset stomach, diarrhea bone. skin changes, heart problems, elevated serotonin, the cause, and dyspnea breathing issues covers the main points.
FLSA. Okay, great. So if carcinoid is suspected, what investigations are typically done?
Right, the workup often starts with biochemical tests. The key one is the 24-hour urinary 5-HIAA.
5-HIA.
Yeah, measures that serotonin breakdown product in urine over 24 hours. High levels, especially over 25 milligrams, strongly suggest carcinoid syndrome. But you need to be careful. Certain foods, meds can interfere.
Okay, good caveat. What else?
Plasma chromogranin A, it's a more general marker for neuroendocrine tumors. It's sensitive usually up if a NET is there, but not super specific.
Okay.
So often used for screening or tracking treatment.
And other bloods.
Yep, baseline stuff. FBC, LFT's liver function is key. TFT's thyroid function, maybe parathyroid hormone, calcium, calcitonin, prolactin, AFP, CEA, beta-HCG, basically ruling out other things or associated conditions.
Right.
Sometimes provocative tests are considered if things are unclear, but carefully, because they could trigger a crisis.
Okay. And what about actually seeing the tumor, imaging?
Absolutely. For GI tumors, endoscopy, endoscopic ultrasound are vital for diagnosis, biopsies. Barium studies might occasionally show something. Then you've got CT and MRI scans, maybe even laparotomy, to find the primary, see how far it's spread, look for METs, especially for gastric intestinal tumors.
And there's special scans.
Right, the scintigraphic imaging, using tagged somatostatin analogs, octreotide scans, basically. Very good for finding tumors with somatostatin receptors, which many carcinoids have. Shows the primary site and any spread.
Like gallium dotatate PET.
Exactly, that's a common modern version. There's also somatostatin SPECT imaging. And for the lungs, if you suspect a bronchial carcinoid, especially with a persistent pneumonia, bronchoscopy is key direct look. Take samples.
Okay, quite the arsenal of tests. Any way to group them mentally?
Yeah, maybe think. What are we measuring? So hormone markers first, 5-HIA, chromogranin A, then general health checks and rule outs other bloods, then imaging to find it, look inside, endoscopy, get the big picture, CT, MRI, and then target the tumor specifically, nuclear scans. See the hormones, see the body, see the tumor.
See the hormones, see the body, see the tumor. I like it. Okay, let's shift to the crucial part. Management. How are these treated, say, in the UK?
It's very much tailored to the individual. Depends heavily on, location, extent how far it's spread, how aggressive it looks, and whether there are metastases.
And the main goals?
Two main goals, really. Remove the tumor if you can, and control the symptoms and hormone effects.
What are the main tools in the toolbox?
The notesless surgical removal, that's the ideal if it's localized. Then symptom and hormone control, primarily with somatostatin analogs like octreotide.
Okay.
Targeted therapies, chemo, radiation therapy also have roles, especially for more advanced or spread out disease. It really needs a multidisciplinary team. Oncology, endocrinology, surgery, all working together.
Can you give specifics? Like, how do you manage that difficult diarrhea?
Yeah, for diarrhea, sometimes drugs like cyproheptadine can help. And importantly, especially with metastatic disease causing the syndrome, avoiding triggers alcohol, spicy foods is key.
Right. And tackling the tumor itself.
Surgery is preferred for localized tumors. You just want to get it out. Surgery might also be an option for liver mets in some people. And those somatostatin analogs like octreotide, they're vital for blocking hormone release, easing the syndrome symptoms.
What if surgery isn't possible or doesn't get it all?
Then you look at other things. Biotherapy, like interferon. Targeted radionuclide therapy delivering radiation right to the tumor cells. Chemotherapy has a role, though maybe less effective than in some other cancers.
And for really advanced disease.
Often it's about symptom relief with the somatostatin analogs and maybe surgical debulking, removing as much tumor as possible, even if you can't cure it, just to reduce the hormone load.
Any other specific therapies mentioned?
Yeah, interferon alpha, again, for resistant syndrome symptoms. External beam radiation for painful bone mets. Chemoembolization, targeting chemo directly to liver mets. Liver transplant is a possibility in very select cases. And if the heart valves are damaged, surgery might be needed for that.
So a lot of options depending on the situation.
Wow.
Key takeaway for the approach.
Think priorities. First, control symptoms, hormones. Second, remove tumor if feasible, surgery. Third, target remaining disease, systemic therapies.
Symptoms, surgery, systemic. Got it. Okay, what about the long-term picture? Prognosis.
It really, really varies. Depends hugely on the stage at diagnosis, where the tumor started, and if it is spread.
So early detection is vital.
Absolutely. Early detection, getting the right treatment quickly, and then ongoing monitoring. Having underlying genetic syndromes or other health issues can also impact things.
Any positive trends mentioned?
Yes, definitely. Better diagnosis, better surgery have improved outcomes. The notes give some median survival times. Localized small bowel tumor, maybe 170 months. Regional spread, around 145 months. Even with liver mets, if you can do aggressive surgery on them, survival can be over 100 months.
That's quite encouraging, relatively speaking.
And for lung carcinoids, the 5-year survival is actually very high, like 96%. So that's really good news. But remember, these are averages. Individual experiences vary.
Important perspective. Okay, lastly, complications. What can go wrong?
Well, carcinoid syndrome itself is the big one. Flushing, diarrhea, wheezing, bowel obstruction if the tumor blocks the gut. Those heart valve problems from fibrosis, carcinoid heart disease, liver mets developing if they weren't there initially, and nutritional deficiencies like that tryptophan issue. And generally, bigger tumors are more likely to spread.
And we definitely need to talk about carcinoid crisis. Sounds serious.
It is very serious. It's a sudden, severe worsening of the syndrome symptoms. Massive release of hormones from the tumor leads to cardiovascular collapse, dangerous low blood pressure, fast heart rate, confusion.
What triggers it?
It can happen spontaneously, but often triggered by surgery, anesthesia, even some procedures. Critically, though, it's often preventable. Giving an octreotide infusion before and during procedures in known carcinoid patients is key.
And if it happens?
Immediate 5V octreotide infusion, supportive care, maybe plasma, quick action is vital.
Crucial point. Okay, so to wrap up this deep dive, we've covered definition, causes, risks, pathophysiology, differentials, epidemiology, clinical features, investigations, UK management, prognosis, and complications like that carcinoid crisis.
Exactly. Hopefully, we've pulled out the core high-yield stuff to give you a really solid base for revising carcinoid tumors.
Definitely. And remember, for more fantastic revision resources, do check out pastthemsra.com and also freezesra.com.
And just one final thought to leave you with.
Yeah.
Consider that paradox again. These tumors, often slow-growing cells,
Right.
but capable of causing such dramatic body-wide effects through hormones. What unique challenges does that create for diagnosing early, for treating effectively long-term? It's something researchers are still actively tackling.